Going to talk about ethics in palliative care today. Basically, trying to figure out a proper definition and, look at the four cardinal principles of palliative care and something which you all, are very eager to maybe discuss, which is euthanasia. So, by definition, ethics are a moral code of behavior, basic behavior that we as humans show towards our, fellow people, our patients, our colleagues, and of course, friends and family also. So this particular behavior, human behavior, is actually grounded or actually governed by certain principles which are known as ethical principles. And these ethical principles, these are basically a set of principles that are in a moral account, should function as an analytical framework which expresses the general values underlying common morality. So this particular definition of ethical principles is, you can actually understand word by word what it means and how, how we should be applying that in a day-to-day life, particularly relevant when we are talking about our professional work. So ethics of palliative care are those of medicine in general. And doctors have a dual responsibility, not only doctors, but everybody who's related to patient care. They have a dual responsibility to preserve life as well as to relieve suffering. But since we are talking about palliative care, and more than 70 to 80% of our patients are at the end of life. We deal with patients who are going to die at one point of time very soon. So at that particular stage of life, the relief of suffering is more important, as the preservation of life becomes increasingly impossible for us. So this is what we have to understand when we apply ethical principles in palliative care. So there are four cardinal principles for palliative care practice. Number one is patient autonomy, which basically answers the questions of what does the patient want and does the family understand the patient's preferences. I'm going to elaborate all these principles through examples in my next slides. So the second one is beneficence, and it basically answers the question of, will any of our actions benefit the patient? Any kind of decision that we have made for the patient, kind of a treatment that we are following for the patient, or a change in our decision, is it going to benefit the patient? And then the thirdly is the principle of non-maleficence, which answers, will it harm the patient? Like whatever we are going to do, is it going to harm the patient? And last but not the least is the principle of justice, which basically deals with fair allocation and utilization of resources. So I'm going to discuss one by one, but before that, we have to understand why we are actually, discussing palliative ethical principles in palliative care. So this certain situations, when we are dealing with palliative care patients, or trying to figure out what would be the best course of action for a particular patient, whether the patient is terminal or not is immaterial here, but the point that will always be difficult to answer, the question that will always be difficult to answer is this particular action that we are going to take for the patient is going to be okay for him? Is it going to change his prognosis? Is it going to give him the best that we want to give him? So those particular situations are called ethical dilemmas. So basically, ethical dilemma is a conflict of moral principles. Okay, uh, it occurs when a person faces certain situations where adhering to one particular principle might result in the violation of the other. For example, when you know, we are taking a decision for, giving certain kind of a medicine, starting perhaps a new drug for a patient. And we know that this particular medicine has a lot of side effects. And those side effects might, harm the patient. But we also know that this particular medication is also going to relieve, or treat the patient and, give him a better course of life. So, but then, we are in a dilemma. We are in a situation where we understand both of these problems and we are not able to take a decision. So, how do we actually deal with dilemmas? So, this is what is about ethical dilemma, and henceforth, we have to understand and prioritize, which principle to follow, or which principle will have a priority over the other. So let us discuss one by one, some dilemmas so that you understand this particular point. As you can see in this picture, this is a patient who has a orocutaneous fistula because of a jaw tumor. Okay, and he's an elderly patient. He's in severe pain, but fortunately, there is no distant metastasis. The doctor is quite confident, the oncologist is quite confident that, you know, this patient can be treated and this particular situation could be averted. A problem that might come because of metastasis might be averted because there is no distant metastasis. Now, the doctor advises NG tube insertion in order to, proceed for further treatment. But the patient refuses to take the NG tube. Okay, so NG tube is Ryan's tube. So the patient refuses to take the Ryan's tube. Now, what is going to be our stand in this particular situation? So, how do we generally approach this patient will actually give us a way to take the right decision for this patient and then, proceed afterwards. So this particular dilemma is between doing good, which is beneficence, and the choice of the patient, which is patient autonomy. Now, when we say doing good, it is the decision of the oncologist to proceed further with the treatment, for which the first and the foremost thing that he would want to do is to insert a NG tube. And but since the patient is refusing, we also have to give an importance to the autonomy of the patient. So there is a dilemma between the autonomy of the patient, of the autonomy principle, and the principle of beneficence. So how do we deal with this? What are we going to do? Are we going to actually, not take, the autonomy of the patient and go ahead to benefit the patient, or are we going to just listen to the patient and then not do the surgery or not do the NG tubing. So here we have to understand what exactly is patient autonomy. Okay. Now, what happens is that in patient autonomy, the patient is completely involved in decision making. Okay. And when we say involved in decision making, uh, these the four things, the four important points that we need to remember is that the patient has a right to have dignity, privacy, and confidentiality. The patient also has a right to have the correct information. The patient also has the right to make his own decisions. And the treatment decision, whatever would be taken, has to come as an informed choice of the patient. So these four important points together make up the patient autonomy. Now, excuse me. How do we approach this particular patient that we have seen, which gave us a dilemma between doing good, which is beneficial, and the autonomy of the patient. So now, for this particular patient, the autonomy is an informed refusal. Okay, we need to understand, why the patient is refusing. So check the understanding of the patient first. Does the patient understand what process would be done to him? Does the patient understand what is the importance of giving a Ryle's tube at this particular point of his treatment? Does the patient understand the benefits of putting in the right tube? Okay, and does the patient understand the fact that after the treatment the Ryle's tube can also be removed? So you need to check the understanding of the patient. Secondly, you explore the reasons why the patient is refusing. Okay, the patient might be thinking that this tube will be inserted through my nose, and it will go inside my brain and I will die. Okay, many of our patients who are from the lower socioeconomic status, they do not understand, and for that reason patients who are from the higher educated status also have certain kind of uh, prejudices or certain kind of misunderstandings that you something would be inserted through my nose, it will go directly to my brain. Okay, I will have seizures, I will die of bleeding, I will not be able to breathe. All these reasons you need to explore. Okay, and when you explore these reasons, when you know what the patient is thinking, the kind of misconceptions or myths that the patient is harboring, you can actually go for a proper counseling. And when we say counseling in palliative care, we are actually giving the right kind of information to the patient and trying to remove the misconceptions. Okay, not like you have to hammer the patient all the time. No, 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 you have to do it. It is going to save your life. Not like that. You need to counsel him by giving him the right kind of information and removing the misconception that the patient has. And last but not the least, when you have checked the understanding, when you have found out the reasons of his refusal, and you have also given your best to counsel and remove all his misunderstandings, but still the patient does not agree with your decision, then you have to support the patient even at that point of time. Okay, you have to win the patient's confidence that you are there with the patient whatever happens, even if he is not listening to your decision. you are supporting the patient. Okay. So always remember that when you support the patient actually remembers that particular behavior that you have shown to him. He goes back home, and he remembers and tries to comprehend everything that you have told him. And then in my career also, I found that such patients will refuse for 1 day, 2 day, third day also. But at the fourth or the fifth day, they'll actually come back to you again to tell you that, doctor, you're right. I would actually, go with your decision. So this is how you actually take a informed refusal of the patient and support the patient, and at the same time you keep your door open for the patient to come back to you. Okay. And then once the patient, you are able to win the confidence of the patient, you are sure that he's going to be better. All right. So I'll come to this particular boy, this particular case also. This is another dilemma. This is a 20-year-old boy with osteosarcoma of the lower end of the femur. He has a large tumor. He has multiple lung metastasis. He has severe anemia. Now he wants an amputation, but the procedure is too risky considering his general condition. So you explain the risk to him, but he wants to continue with the amputation. So what should be done in this particular case? Okay. Now the dilemma is between doing good and avoiding the harm. Okay. Doing good because the patient is actually wanting to have a um, uh, he's wanting to take the risk of surgery, and hence trying to benefit. But then you also know that if you do this particular surgery, you are going to perhaps the patient might die during the surgery, and hence you are trying to avoid the harm. So this is a dilemma between beneficence and non-beneficence. So now, how do we approach these patients? The question that we need to answer here is, what are his chances of cure? You already saw that this particular patient is in a terminal stage. Okay, he has multiple lung metastasis. He is in stage 4 cancer, and perhaps he may not even make it for another 1 month or so if we prognosticate. So we need to understand and answer this particular question, that what are his chances of cure? Are we going to take the whole cancer out of his body? If we amputate the leg, are we also going to take out metastasis from the lungs? Is it going to reduce? Okay, so this is one question. And when we say, talk about cure, uh, um, is the survival of this patient likely? Okay, and the question that, will this amputation improve his condition further? Okay, is it going to improve, or is it going to make it more worse? So these are the questions that we need to answer in such particular patients. Another dilemma that you will you might face is a similar young boy who has an advanced cancer, and the relatives have actually insisted that the issues of diagnosis and prognosis should not be discussed with him. But when you go to see him one day, he's all alone in the ward, and he, asks you what is wrong with him. Now, what will you tell him? Okay. Relatives have insisted that please do not talk to him about the diagnosis. Do not tell him what has happened, and Do not tell him what is going to happen. Okay, do not tell him the prognosis. So the question that comes here is it right to deliberately mislead a person or to withhold information that a person is asking for at the insistence of the patient's relatives? Is it wrong or is it right? Okay, so you will be faced with such kind of a dilemma. You will need to then take a decision about how to deal with this particular situation. You know that the patient has all the rights because it is his autonomy. He is asking for the information. You, as a doctor or a personal healthcare personnel, must actually give the right kind of information to this particular patient. Okay, a 20-year-old boy is already an adult. Okay, secondly, we also will need to understand that why are the patient's relatives insisting not to tell this person, their patient, about the diagnosis and the prognosis. Okay, so the question here is, how do we approach this patient? So these kind of situations generally demand a lot of perseverance from our side and a lot of good communication skills. Okay, so you will have to deal with the patient's relatives, find out why they are not actually trying to divulge this particular information to their patient. Okay, you will also have to respect the fact that for the patient's relatives, it is the patient is will always be a child, so they would want to protect that child, okay, from any kind of harm, and that harm might always be because of the fact that they are thinking, if our boy comes to know about his diagnosis, he will have he'll have a shock of his life. He might also die because of this shock. And believe me, this particular notion, has very interestingly stamped by our great Bollywood movies, because you might have seen in many of our movies that the doctor comes and says, divulges an information to the patient, and that patient has a heart attack and is dies. Okay, so this kind of situations are actually, I have never seen this kind of situation happening, and these are very funny things that are propagated by Bollywood movies, and these are absolutely wrong. At least in my career, I have not seen these things happening. So on a serious note, we will need to perhaps talk to the patient's relatives, um, uh, taking out some time separately, and then also talk to the patient about, what. But if you ask me what to do just at that particular nick of time when the patient is asking for that information, I would actually, advise you to just handle the situation and tell the patient that, okay, I am a little bit in a, I'm going to see all my patients, and I'll find out a proper suitable time for you, and then we can discuss about this. Okay, so this is how you're going to handle, right? Talk to the patient relatives in a separate way. Convince the patient's relatives that it is important for the patient to know about his diagnosis, his prognosis. uh, you know Tell them that there is not much time left, and they have to utilize this time to fulfill, you know uh, uh, not all, but at least some of the most important wishes that the patient has. Okay, And unless and until the patient knows about his or her diagnosis, he will not be able to, tell his wishes, his last wishes. So this is how you are going to handle it. Another very interesting, case that we generally get in the end of life. This is a patient, 50-year-old lady. She has a carcinoma of the stomach. She has come to the hospital in a terminal state, and the terminality is probably due to an internal bleeding of the CA stomach. Her systolic BP has fallen to 50 millimeter of mercury, and she's extremely restless. Now, will you give her parenteral midazolam, which might hasten death? Okay, so if 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 you have already been have attended the class on uh, terminal or end of life care, you might be knowing that parenteral midazolam is the gold standard of treating terminal restlessness. Since this patient is already in a terminal state, and having restlessness, then we generally do advise parenteral midazolam, but knowing the fact that midazolam might hasten deaths. So why do we take this decision? There's something, so the question is, will it be right to give some medication to a terminally ill person which might inadvertently hasten the person's deaths? Now, something that we all should know while practicing palliative care is that uh, there's a principle called the principle of multiple effect. And it states that a single act having two possible forcing effects, one good and one harmful, is not always morally prohibited if the harmful effect is not intended. Okay, so I'll explain to you in detail about this particular statement by taking the example of a drug that we use very, very often in our palliative care practice in pain management, which is oral morphine. Now, we all know that oral morphine has, causes lot of side effects. The most important and common ones being constipation and dryness, nausea and vomiting. Okay, so now are we not inducing or inducing nausea, vomiting, and constipation for a patient by prescribing oral morphine? We are. And that is a harmful effect of this particular medicine. Okay, but the good effect, the positive effect of this particular medicine is that it is going to relieve the patient of the intractable pain that he is having. Okay, so we are using morphine, but at the same time, we know that it is going to cause nausea and vomiting and constipation. That is the reason why we use, anti-vomiting agents, anti-nauseating agents, and at the same time, right laxatives for constipation. Okay, so this is a very simple example. For another example might be the use of anti-hypoglycemic agents. Okay. For diabetics, anti-hypoglycemic agents might also cause, severe hypoglycemia. Okay, but are we not prescribing anti-hypoglycemic for diabetes? It is important, right? We know that it has a dual effect, and one is good and one is harmful. So this is called the principle of double effect. When we have to remember, principle of double effect applies to many of our strategies or treatment options or medications that we use in palliative care, particularly, at the end of life. Since we have a dual responsibility to, treat the patient and to preserve life, and as well as to relieve the suffering. So when the patient is at the end of life, the main responsibility that we have is to relieve the suffering. So this is another example, and very interestingly, this particular gentleman has an advanced cancer of the lung. He's completed a course of radiotherapy and 2 courses of chemo. He's brought to the casualty. He's drowsy. His pulse is feeble. He has a systolic BP of 60 millimeter of mercury, and the breathing pattern is altered. Now, the family wants everything possible done for the patient. So, what do we do in such a situation? Do we resuscitate and shift him to the ICU? Do we investigate more? Do we, look at the hemodynamic and ventilatory supports, hydration and nutrition? I would like to leave it to you to, decide on this particular dilemma. Please discuss among yourselves and decide on what to do, what would be the best thing to do for this patient. Having said this, the patient, when there's something called the appropriate treatment that we need to follow, okay? And it is a treatment that does not provide net benefit to the patient, which may ethically and legally be withdrawn. And the goal of medicine should be to shift towards the palliation of symptoms. And when we talk about the key points in an appropriate treatment, it is always the patient's biological prospects, the therapeutic aim and benefits of each treatment that we decide on, and the adverse effects of each treatment, and the need of not to prescribe a lingering death. So these are the key points of appropriate treatment for a patient, and basically at the end of life. That brings us to the principle of justice, balancing the needs of the individual with that of the society. So this is an example of a war journalist. He's 86-year-old. He has cancer of the lung, which has spread to the spine, the ribs, and the sacrum. He has a responsibility of a son who has a psychiatric disorder. He has 6 grandchildren, and the goals of care are like that of taking care of the pain, taking care of the family finances, the Geneva Sanskar, but also the fact that the breathlessness is increasing. So are we going to put him inside the ICU? He's already 86. He's already breathless. He has, all financial responsibilities towards one of his psychiatric sons. He has so many things to, give it to the grandsons also. So all are we actually going to take towards the ICU admission of this very terminally ill patient? Will it be a fair utilization of the family's resources, allocation of the hospital resources, of the societies or nation's resources, where we have so many patients, coming to us every day? If you have seen bigger, tertiary care cancer hospitals or even medical colleges, you'll find that it is so difficult that our patients go through such problems, and they do not proper resources to be for a treatment. And that brings us, to this important topic of euthanasia. Are we actually going to kill these people who are, who are perhaps in the terminal stage of life? So, euthanasia has been defined as an act or procedure in which someone takes an active means, such as a lethal injection, to bring about someone's death. But always remember that allowing natural deaths to occur by means of withholding or withdrawing a futile treatment is not euthanasia. Okay, it is legal in countries like Netherlands, Belgium, and Luxembourg, but not in India. We do have a legal provision under IPC section 88, and it says that nothing which is not intended to cause death is an offense by the reason of any harm which it may cause. Then, for a patient who has given a consent, whether express or implied, to suffer that harm or to take the risk of that harm. Now, the point is, we do have this legal provision, but we have never, been able to apply it in practical terms. Okay, so now, the Indian Society of Critical Care Medicine and the IAPC have jointly actually, come up with a legal battle. They have fought a legal battle for this particular point, and at least there are certain clauses being laid down. One of the most important one being the advanced directives. And advanced directives, once they are in place, perhaps will be able to justify why we are not allowing euthanasia to happen. We all know about futile care. Physicians are not ethically obligated to deliver care that, in their best professional judgment, will not have a reasonable chance of benefiting their patients. So this point is extremely, extremely important. So why do actually physicians go for a futile care? That is because they're not oriented to curative treatment. They are oriented only towards curative treatment. They do not have a training in palliative care, and that is the reason why today we are discussing palliative care. There's always a fear of being blamed for suboptimal treatment, okay, and an ignorance about the guidelines for end-of-life care, and the question of euthanasia. So this is the reason why our physicians are always inclined, or perhaps, somewhere forced to do a futile care. Now, I would encourage you to please go through this particular paper, which is the end-of-life care policy and integrated care plan for the dying. It is available in IAPC, in the Indian Journal of Palliative Medicine. It is a free paper. Please do go through it. They have actually lined out a 12-step process for the end-of-life care, and that will really help you in taking care of people at the end of life. So there is a moral distinction between killing and letting die, and hence euthanasia would always be a deliberate intervention undertaken with the expressed intention of ending life to relieve the intractable suffering. So using morphine and other drugs to relieve pain, stopping treatment when the burden outweighs the benefits, allowing nature to take its course is not euthanasia. I would like you to please go through this particular book written by Atul Gawande, which is Being Mortal, and he has very explicitly actually described about certain touched upon certain points of euthanasia, points about medical ethics, points about which thing to do, which is, a practical implication of his own experiences. So kindly go through this book. So cannot afford to die in the ICU because of so many reasons. Most of our out of pocket expenses in India are almost, touching 85%. So many million of Indians are becoming poorer per year due to the rising healthcare costs. Most are related to aggressive medical interventions at the end of life. And interestingly, there'll be a 300% increase in inpatient expenditure in the last 10 years. Okay, so basically, from this particular session, the take home message that I can actually make out for you or jot down for you is apply the ethical principles against a background of the respect of life and the acceptance of the ultimate inevitability of death. So when I die, I would like to spend my last hours or last days with my family, with my friends, at home, and not, surrounded by machines. So thank you so much for this patient hearing, and I hope I was able to describe and explain medical ethics for you. It is a huge subject, but you can keep on adding your own experiences when you start practicing them, and you can actually build up your own um, ethical dilemmas and the ways how to handle them. So all the best to all of you, and thank you so much once again.